kidney.
Hello, Doc. Please, if you can voice out small.
I haven't eaten.
Sorry.
You want me to hide?
No, please.
So let's talk about anatomy, small anatomy of the kidney. Small. Can you hear me? Those who are complaining, can you hear me? Anatomy. So when you talk about kidney, note this: that kidney is a paired organ. It's a paired organ. Kidneys. 2 kidneys. So it's a paired organ. And these paired organs are situated at retroperitoneally. I have to use the mouse to write, and that is making it difficult. So it's a paired organ and it's situated retroperitoneally. Retroperitoneal is located at that. So find out what is this where is the location when you say it's located retroperitoneal. The next thing that I'll talk about is that is the kidney size, the size of the kidney, and it's very important, the size of the kidney, because we use the size of the kidney to do diagnosis. It's important to know the size of the kidney. So the size of the kidney, so the length, who can tell me the length, the range? We are talking about the size of the kidney. So the kidney size, who can tell me the length? The length of the kidney. Class, who can tell me? Who can tell me, please? Can you hear me?
Yes, sir.
I'm going to ask questions. Questions. In my teaching, I ask questions. I want to know the way you answer questions. Because in your professional exams, we have oral portion. You should know how to answer questions. So in my teaching, I ask a lot of questions. Okay, so who can tell me the size of the kidney?
Okay, so what I know, it's between 10 to 13 centimeters in length.
So yours is 10 to 13 in length. What again? The width is what? And the depth is what? So if we are talking about the size of the kidney, we talk about the length, we talk about the width, and we talked about the depth. These will give you the size. So the length of the kidney ranges from 11 to 14. So check, this is for adult. This is for adult. Check that for children. This is for adults. So you look for the size of the kidney for children. Look for that. This is for adults. So for the adult, the length is 11 to 14 centimeters. The width is 5 to 6 centimeters. And the depth is 3 to 4. 3 to 4. So this is the size of the kidney. I said that I said that the kidney is a paired organ. The kidney is a paired organ. It's situated retroperitoneally, and the size of the kidney it's 11 to 14 centimeters. The length, the width is 5 to 6 centimeters, and the depth is 3 to 4 centimeters. So, in chronic kidney disease, one of the parameters that points to chronicity is the size of the kidney. So when you are talking about chronic, then this will play a part. In acute, the kidney size is normal. But in chronic, we have reduction in kidney size. So the size is very, very important. Please, can you hear me? Can you hear me?
Yes.
Mavis, can you hear me? Mavis, can you hear me?
Yes, please, I can hear.
Mavis, are you doing something different from what we are doing?
No, please.
Okay. The next thing I will talk about it is that when you take the kidney, when you take the kidney, or I will say that the kidney cells or the renal parenchyma, if I say renal parenchyma, I'm talking about the cells of the kidney. The renal parenchyma comprises of two layers. The renal parenchyma is basically divided into two. So we have the cortex. So it means the kidney is basically divided into two. We have the cortex and we have the medulla. And this is very important. We talk about this. So the renal parenchyma comprises of cortex and the medulla. And each kidney, we said it's a paired organ. Each kidney is made up of about million nephrons. Each kidney contains about or approximately about million nephrons. When you talk about the functional unit of the kidney, the functional unit of the kidney is the nephron. The functional unit of the kidney is the nephron. So now let's talk about the functional unit of the kidney, which is the nephron. Please, any question up to this point? Please, any question? Okay, so let's talk about the nephron. So we said that the kidney is divided into two. So we have the cortex here, and we have the medulla here. So the cortex, these are the parts that are found within the cortex. So we have a Bowman capsules here. So we have Bowman capsules here. So we have the proximal convoluted tubule here. Okay. Okay, so help me to label this. So this is rough sketch of the nephron. This is the risk. I'm saying that the kidney is made up of about 1 million. So each kidney contains this. So there will be filtration in each of the nephrons. And this will end up with the collecting duct. Collecting duct will take all these waste out of the system. So help me to label this. So part A is called what? And part B is called what? Can you see from the board? Can you see
Yes,
my whiteboard?
yes, you can see.
I want the response to come when I ask you questions.
Yes, sir, we can see.
So part A is called what?
Efferent artery.
Afferent arteriole.
So we have afferent. Afferent. We have afferent. B is what?
Efferent
Efferent.
Efferent artery. C, part C is called what?
Bowman's capsule.
So part C is called Bowman capsule. So we have this to be the Bowman capsules. Part D is called what? The D capillaries within the Bowman capsules are called what?
The glomerular.
glomerulus.
The glomerulus. So we have glomerulus here. So this side is called what? So this side is called the proximal convoluted tubule. This is what? This is what?
The ascending and descending loop of Henle.
So this is descending and this is ascending loop of Henle. This is descending and this is ascending. So if I ask you about the mechanism of Lexis, where does Lexis act?
Take ascending limb of the loop of Henle.
So Lexis will be acting at where?
Descending loop of Henle.
Is it descending or ascending?
Ascending.
Ascending.
And the
Some might say descending. I hear. Which part is this? F is this. F is what? And G is what? Which part is this? So this is distal convoluted.
Distal convoluted tubule.
So distal, and this is what? And this is the collecting duct. And this is the collecting duct. I want you to know this. I say that the renal parenchyma, if I use the word parenchyma, it's talking about the cells of the kidney. When I use the word parenchyma, renal parenchyma, it's talking about the cells of the kidney. There's a nice structure here, found here. Nine structure found here.
Hello, doctor.
Yeah. Yes.
So please, on top of your A, is it F? The F. Please, what did you say the F is?
Where?
Before the G, the letter there. Yeah. What did you say was, please?
Who can tell me?
Distal convoluted tube.
Distal convoluted tube.
Okay.
Are you
Thank you.
okay?
Yes, sir.
Okay. So I'm going to say certain things, please. I'm going to ask you questions. There's a structure beneath the afferent artery. There's a structure beneath the afferent artery. This is a rough sketch. And this structure is called juxtaglomerular apparatus. Juxtaglomerular apparatus. And this structure, who can tell me the function of this structure over there? Who can tell me the function of the juxtaglomerular apparatus?
The production of renin.
So it does produces what? Renin. And there's this boundary, which is, or junction, which is separating the cortex from the medulla. The cortex from the medulla. What is the name of this boundary? There's a boundary that separates the cortex from the medulla. C from M. What is the name? Hey, can you hear me, class? I said that the renal parenchyma comprises of two regions. So we have the cortex and we have the medulla. And there's this line or boundary or junction that separates the cortex from the medulla. What is the name? And it's very important. What is the name?
Cortex medulla junction.
What? Cortex medulla junction. Any other? Who said it? Is it Hillary or me? Or what is the name of this? Somebody said cortex. Come again. Come again. Your line is breaking. So this is corticomedullary junction. Corticomedullary junction. This is corticomedullary junction. Very, very important. At times at the ward, at the renal team, at the ward, they'll be talking about good corticomedullary junction or poor corticomedullary junction. I will talk about it when we get to. So this is corticomedullary. Nana, are you there?
Yes, please.
Can you mute? Can you mute them for me?
Yes, please.
Okay. So this is corticomedullary junction. Okay, so things I want you to know from this is that who can tell me the difference, please, from the rough sketch? Who can tell me the difference between the tube here at the medulla, and the tube at the cortex? So note these things. Very important. Note these things. The tube and the cortical level, the tubes of the nephrons found at the cortical levels are always thick. We have thick loops. Thick loops at the cortical level. The tube at the cortical levels are always thick. The tubes at the cortical levels are always thick. The tubes at the cortical levels are always thick. And the tube and the medullary levels are always thin. So we have thin, and we have thick. So you can see from the rough sketch, you can see we have thin here and thick loops here. But we have these thick loops. Under normal circumstances, we are supposed to have thin loops. The tubules here should be thin. But the thick loops, the thick descends a little bit to the medulla. Descends a little bit to the medulla. So note this. I'll be asking you why we have thick. Thick are always found at the cortex. And you have thin and the medulla. But there's this thick loop descending a little bit to where? To the medulla. This thick also descending a little to the medulla. So this is the way the kidney works. So blood from the system will get into the kidney via the afferent arteries. So the afferent arteries will bring the blood into the Bowman capsules. And there will be a filtration. The smaller capillaries within the Bowman capsules, which is called glomerulus, there will be filtration. And this filtration will go through here and gets into the proximal convoluted tube. So, at the proximal convoluted tube, there will be reabsorption. There will be reabsorption at the proximal convoluted tube. So the filtrate going through the Bowman capsules contains sodium, contains potassium, contains magnesium, contains urea, contains amino acids, contains a lot. When they get into proximal convoluted tube, about 80% of the things within the filtrates will be reabsorbed. Note this, about 80% to be reabsorbed. And 20% to go through this. When this 20%, I'll be talking about these things again, the thin and the thick loop. There'll be reabsorption of the 20% going through this here and here. And the rest of the filtrates that would get into the distal convoluted tubule. Also, there'll be reabsorption of the things within the filtrates at the proximal convoluted tubule. Then they will get to the collecting ducts. The system will get rid of it, will excrete it, the rest. So the body would take everything. The body would take what it needs. So it will be for normal kidney will not allow anything that the body needs out. Will only excrete the excesses and what the system doesn't want. What the system wants, like potassium, the body will reabsorb, will cause reabsorption of all this back into the system. Glucose, the body would unless we have excesses, and the body will excrete it. If we don't, the body will take it back. So back to my question. Why do we have this thick loop down here? What is the essence? Under normal circumstances, we shouldn't have this thick loop here. What is the thick loop doing here? Thick loop doing here, below the corticomedullary junction. What is the thick loop doing down here? What is the essence of having this thick loop down here? Who can help me? Am I talking to the class?
Hello, Doc.
Yeah.
This is Solomon.
Solo?
Yes, Doc. Yeah, like you rightly said, when the filtrates from the glomerulus get into the distal convoluted tube, the body tends to absorb some of the element that is in it, as in the potassium, glucose, all those stuff that the body needs. So not all will be absorbed. So some will never want to pass through the tubes again. When they get down here, where we have the thick loop, there will also be another absorption to enable all the minerals, all the element that the body needs to be properly absorbed. That's how we have from the thick loop down there.
So what is the essence of the thick loop below the junction?
To help reabsorb other element that will want to pass through, that will not absorb. The 20% is not absorbed.
There's a noise behind. Hillary.
Yes, please, I'm about to mute them.
Can you tell them for me?
Yes, please.
This is why I don't like Zoom. Because you'll be there, but you'll be doing different things. You're doing different things. Okay, I'm asking you, Hillary, help me. Why do you have this thick loop, small thick loop here below? Hillary, are you there?
Yes, please. Please, can I call someone to help?
One that you hit to help. Right.
Please, Kojo or Stanley, kindly help us.
Stanley. Stanley.
Oh, Dr. Attakorah.
Mm-hmm.
Yeah, I think that that area would be thicker because of the reabsorption that will take place. I'm not really sure why there be a difference, but I think that if more ions would be reabsorbed there, probably there should be a need for it to be thicker to handle that that exchange that would have to happen there.
Under normal circumstances, you shouldn't have had these here, a tick here, but God has made a tick to come under, small tick within the medulla for a purpose. Listen.
Yeah, so I think it's good because that's the reabsorption of water. I think the tick lobes are to build a form of concentration gradient so that the water can be reabsorbed and then the ions can be reabsorbed into systemic circulation.
You have an idea. I like that. Good. So what is hi?
I think that the reason why the tick goes beyond the medulla is because of the fact that there's this thick in order to prevent water reabsorption. And since the principal convoluted tubule is primarily supposed to filter out the essential micronutrients that the body needs. So, it goes beyond into the medullary region to capture those ones and also prevent water from being reabsorbed by the body so that it can be moved down the loop of Henle.
Okay, so let me tell you. So good attempt. Well, let me tell you. Do you know there's a tick here, and take note of this. All the time, the tick loops. There's exchange of electrolyte and the tick loops. Not only electrolyte, the glucose, the urea, and the electrolyte. Exchange occurs at the tick loop. And the thin loop, the thing here, there's exchange of what? Water. So exchange of electrolyte, exchange of glucose and urea occurs at the tick loop. At the tick loop. An exchange of water occurs at the thin loop. So what the reason why the tick is found here? The reason why the tick is found here is that now because exchange of water occurs here, we need to establish a gradient here, hydrostatic gradient here, or osmotic gradient here. And to do that, what it means is that there should be reabsorption of urea, reabsorption of glucose, reabsorption of sodium, potassium, and coal into the medulla. When these things gets into the medulla, it will make the concentration of this area high. The medulla will have higher concentration. And therefore, if medulla is having higher concentration, what it means is that there will be osmotic gradients. There will be higher concentration of these sodium and coal here, higher concentration here. And there will be lower concentration here because we have sodium, we have urea, we have getting into the medulla. It will make the concentration here higher. And therefore, water will move from this side to this side. Water will move from the loop to the medulla, then back into the system. Please, do you get me?
No, sir.
No, sir. No, sir.
I'm taking it again. It's simple. It's simple. I am saying that put this thing down. Very important. I'm saying that the thick loops all the time. There's exchange of electrolyte, exchange of urea and glucose. So the thick loops. What will be happening at the thick loops? That is why plasma convoluted tube will be taking about 80% of glucose, 80% of sodium, urea, and glucose and back into the system. It's happening at the thick. So what is happening is that we have filtrates going through the loop here. We have filtrate, and this filtrate contains water. This filtrate contains sodium, so 80% of these filtrates coming here, 80 will be absorbed, and 20 will move and get into the medulla, and it will pass through this thick loop via the loop of Henle, then to this thick loop again, and it gets back into the cortex. So what I'm saying is that the 20% of filtrates coming contains sodium, contains potassium, contains urea. Please, do you get me? Do you get me to this point? So when these 20% get into this side, what it means is that some of the sodium, some of the magnesium, some of the potassium, some of the glucose here will get into this side. Will be because this side is thick. This side is thick. Some of the glucose, some of the urea, some of the potassium will get into the medulla. So they'll be getting into the medulla via the thick loop down here. So when they get into the medulla, the rest will move. And when the rest also gets here, some will also be taken from here. And I'm saying that the essence of this thick loop is that the sodium, the potassium, the glucose, and the urea that gets into the medulla will make the concentration here higher than the concentration here, because water will not be absorbed via this side. So when these glucose gets into the medulla, sodium gets into the medulla, the concentration over here will become higher than the concentration within the loop, such that water, now if the concentration here is higher than the concentration here, water will move from here to the medulla. So it's not clear.
So I think it's okay. Thanks.
Is it clear? Yes or no? If you say I think it's okay, then you see if you
Yes, it is. Thank you.
If it's okay, you tell me. If it's not okay, please tell me. I want you to understand. Let me know. It's okay. It's not okay. I think it's okay. It means it's somehow. It's so simple. This is the thing. I'm taking it the last time. So we have this. You have the loop like this. Let me say we have the tick coming. We have the tick down here. Under normal circumstances, we have concentration. There's concentration here within the medulla. We have concentration. of the things over there. And the concentration over here should always be higher than the concentration within the tube, such that by osmosis, water will drawn from here water will be drawn. Oh, what is this? So if the concentration here within this medulla medium is higher than the concentration here within the tubules where the filtrates are going through, by osmosis, water will move from the lower concentration to a higher concentration, just to neutralize, to balance the system. So these two thick tubes are here within, under the junction. We have these thick loops, and I'm saying that all the time what happens within the thick loops are that there's exchange of electrolytes. So the thick loops are found more. Thick loops are at the cortex, and thin loops are at the medulla. But we have small portion of the thick at the medulla. And I'm saying that for this small portion at the medulla, is there for a purpose. It's there to ensure that the concentration here at the medulla level is always higher than the concentration within the filtrates going through this, such that water will move from here to this side, to the medulla. Other than that, I'll ask you a question for me to know that it's okay. So these thick tubes are here. The tubes here, thick tubes here, are there to ensure that sodium, glucose gets into the medulla. And when it gets into the medulla, they are going to make the concentration here higher, at the medulla higher. And when the concentration, because of sodium leaving this side, sodium is leaving, glucose is leaving, urea is leaving into the medulla via this stick here. It will make, please hold on for me. Hello, sorry. So what I'm saying is that here, the tick here will cause sodium. The tick here will cause sodium, will cause urea, will cause glucose to leave the medulla region. It will make that region more concentrated. And when that region becomes more concentrated, the thin loop to the medulla, and this water will get into the system. So that's the reason why we have this stick here, such that water will be reabsorbed back into the system. Other than that, water will be getting us. So let me ask you this. If a renal patient comes, normally renal patient should have issue with fluid accumulation because excretion is impaired. But certain renal conditions will come with urinary incontinence. If I say urinary incontinence, please, you understand?
Yes, please.
So, if you understand urinary incontinence, why is it that certain renal patients will be coming with urinary incontinence? Who can explain?
Dr. Attakorah, please, I'm thinking that the gradient won't be established in that the concentration in the medulla won't be higher than that in the loop. So all the water that is being filtered will be filtered out. So they'll be having a lot of urine coming out.
So it means what is happening? What you said, you are right, perfectly right. But can you tell me what is happening if a renal patient is coming with urinary incontinence? What you said is right. But tell me what is happening that is making what you said right.
Sir,
Dr. Attakorah.
The
Hello? I am listening.
so the anatomy of the fluid is going to change. Instead of it being a bit thicker in the medulla, it is going to be thinner. So thereby affecting the concentration gradient that's supposed to be created.
Come again. Who is talking?
The anatomy, please just Adam.
Adam. From where?
Central University.
Central. Okay. Adam.
The anatomy.
Mm-hmm.
Okay. The anatomy of the tube, that's the thick part, would change in a patient with the renal disease. So this amount is going to be thinner, which would affect the movements of the solutes to create that concentration gradient for water to be reabsorbed by osmosis.
Mm-hmm. Any other? So you are saying that the thick will change to be thin. Any other?
Sir, please, probably because the loop of Henle cannot absorb nutrients and concentrate urine in the medulla.
Loop of Henle.
Yeah, it won't be able to absorb nutrients and concentrate urine in the medulla.
The loop of Henle does not absorb nutrients.
Cannot absorb nutrients and concentrate urine.
The loop of Henle does not absorb nutrients.
Hello, Dr. Attakorah.
Yes.
Hello, sir.
Yes.
So I believe that the length of the thick loop has become shorter. So
the length of the thick loop has become shorter.
So it no longer extends towards the medullary region. So that establishment of the concentration gradient where there's exchange of ions and glucose, it's no longer created. So therefore, there's no reabsorption of water. So hence they tend to urinate a lot.
Any other?
Hello, sir.
Yes.
Okay, so
because we established that because of the concentration gradient that is created in the medulla, and then water is able to move from the loop into the medulla, and for patients with maybe patients that have this urinary incontinence, concentration gradient is not able to be created. So instead of the water moving from the loop into the medulla to create that concentration, water is retained in the loop, and then it moves into the concentration now becomes lower, and then the water moves through the collecting duct, and then it will be excreted.
So you have 4 tried. So urinary incontinence, 2 things could happen. And what
Sir.
could yes.
So I was also thinking that is it a thick part that has entered the medulla where the reabsorption is taking place to cause the concentration gradient? Maybe the lining of the thick loops might have lost their integrity to do the reabsorption, to cause the concentration, to increase the gradients, to do the reabsorption of the water from the thin loop. So then there is excess production of urine. And then apart from that too, if the sphincter of the bladder loses its ability to work correctly, it means that the excess urine can't be held for long in the bladder. So the sphincter will allow the person to be peeing uncontrollably, like something like that. That's what I want to say.
So we are thinking about the kidney, not the bladder. So if more urine is getting into the bladder, automatically the sphincter would open to allow. Do you get me?
Yes, sir.
Good. So let's think about what is happening within the kidney. All that you said, the last speaker, I like what you said. 2 things could happen, and it will cause urinary incontinence. One could be that there's a problem here. There's a problem at the thick loops found under the medulla, such that these exchange, the reabsorption cannot occur over there. Please, you get me? And the second, come again.
So please repeat the first part.
Oh, I am just re-echoing what your colleagues just said. The last just said. I'm just saying that 2 things could happen. The first could be there could be a problem at the thick here. The thick here. Can you see the thick here such that reabsorption of sodium, reabsorption of magnesium, urea will not be able to occur to make the concentration here higher. So if there's a problem at the thick down the medulla, such that absorption of urea, magnesium and co cannot occur. I don't know whether it's making sense. Or no, okay. It means that the concentration within the filtrate will be higher than the concentration at the medulla. And therefore, water will be drawn from the medulla into the filtrate within the loop. Then more water will be pushed out. Please, is it clear?
Yes, sir. Yes, sir.
Is it clear to everybody? Please, I want you to understand.
Sure. Hello.
Yes, sir.
Yeah, please, what problem would there be with the thick loops for this result?
Come again.
You said there's a problem. In that case, there will be a problem with the.
I want you to understand first, because a lot of things can happen. A lot of things can happen to this. If there's high pressure and it's causing bursting of this, it could burst this. There could be atrophy here. So there could be a lot of conditions that could cause change this, the functionality of the thick loop under. But I want you to understand the principle. Assuming you have high BP, destroying the. Do you hear me? Please, do you hear me?
Yes, please. Please, I was asking if you could take them, please.
I am saying that if I'm using the word a problem, means that you could have a lot of conditions affecting the side. It could be a genetical by default. This side is not working. What can you say? It could be a disease condition, infection. Infection can affect this side such that the functionality will be impaired. It's also there. High BP. So what I'm saying is that if there's a problem affecting this side, the thick, such that there can be reabsorption of minerals into the medulla, then this will lead to a situation whereby there will be less concentration at the medulla. There will be more concentration within the tube. Then water will be drawn from the less concentration to more concentration. This is the principle I want you to get it. Please, is it clear?
Yes.
Is it clear to everybody?
Yes, please.
Yes, sir.
Another condition is that if something happens to the medulla, there could be necrosis. Cells here. If the cells here, we have a renal cell ischemia. There could be ischemia. Ischemia here at the medulla. And this ischemia can affect the functionality of the cells, the parenchymal cells within the medulla, such that now if there's reabsorption, the concentration will be affected because the cells are necrotic. So what I'm saying is that two things. Something can happen at the medulla such that it will affect the concentration here. The medulla will not be able to concentrate the sodium and the glucose getting into. Or there's a problem at the cortical, the thick loop down the medulla, such that reabsorption can occur. When you have these two issues, it could lead to a situation whereby water will rather be moving from the medulla into the loop of Henle. And this could lead to what we call urinary incontinence. A renal patient, fine, but is having urinary incontinence. Please, is it clear to everybody?
Yes, please.
Any question up to this point before I go on?
Sir, please, can you clarify the point you're making with respect to necrosis occurring?
In respect to what? Come again.
I heard you talk about necrosis. Unless
Your line is breaking. You heard me talking about necrosis and what again?
yeah, but I didn't hear what exactly you were explaining concerning that. So I wanted you to clarify it.
I am saying two things. If you have problem at the parenchyma, cells at the medulla, there could be reabsorption of sodium, urea, and glucose at the medulla, but there cannot be concentration. The cells cannot concentrate. Please, do you get me? If you have
Yes, sir.
If you have problems at the cells, and I said there could be ischemia, because medulla, the cells at the medulla is where most of the activities occur. It's where most of the activity occur. And over there, because of most of activity occur, the problem of getting ischemia over there is high. So the cells could be necrotic as a result of what? Ischemia. So there could be renal ischemia occurring at the medulla. And if you have ischemic occurring at the site, it means that the cells cannot concentrate the sodium, the urea, and co getting into the medulla. And this can also lead to less concentration at the medulla, such that the concentration here within the filtrate will be higher than the concentration at the medulla. This is what I'm trying to say.
Yes, sir. I get to know. Thank you.
Okay, so should I move on?
Yes, please.
Just want to know please, when you don't understand, just quickly prompt me. Don't let me finish the whole thing, then you come back to tell me the whole shoot. Do not, if I use the board, I will not see, if I use the board, I will not see what you put in the chat. Somebody is asking about something. Who can read it in the chat for me?
Dr. Attakorah, please, the question is, in a situation where there's no corticomedullary differentiation, what will happen to reabsorption?
You are chatting as a guest. Who is that? Who is asking that question?
Please, Juan Josephine Ejapoma.
Josephine, if it's like telling me that if you don't have your head on the body, what will happen? Ejapoma, the differentiation is separating the parenchyma cells. The cells at the cortical region is different from the cells at the medullary region. And the activity at the cortical region is different from the activity at the medullary. And therefore, this junction is separating them. And in renal impairment, especially CKD, when we have CKD, I'll talk about it. Something in CKD patients always come with issues with the junction. I'll talk about it. There's a poor corticomedullary junction. Poor corticomedullary junction. The moment the doctors will be talking about poor corticomedullary junction, then it means that the kidney size has reduced. I will talk about it. So please, the junction could be affected as a default. And the junction should be there to separate the cortical from the medullary. So if it's not there, then it means that there's a kidney problem, or the kidney has shrunk. I will talk about it. When the kidney shrink, it affects the corticomedullary junction. When I get there, I will talk about it. So I don't know whether I've been able to answer Josephine.
Dr. Attakorah, please, she said yes.
But in situation where there's no corticomedullary, what will happen to the reabsorption? The reabsorption is not occurring at the junction, please. The junction is separating the cortex from the medulla. The reabsorption is occurring at the cortical part. Let me go to the board again. This is the junction. Josephine, this is the junction. Josephine, are you there?
Yes, Doc, please, I'm here.
Good. So understand, this is the junction. The J is the junction. It's just separating the cortex from the medulla. Where the exchange occur at this side, the cortical region, this side, and this side is where exchange occurs. So if there's a problem here, it would affect the cortical and the medulla. It affects the side. It will not. So the exchange occurs here, exchange occurs here, but not here. This junction is separating the cortex from the medulla. I don't know whether I've been able to satisfy you. Josephine.
Doc, so the reason why I was asking was that if there is no differentiation, from what you just explained, it means that the cells surrounding the extended part of the proximal will be the medulla cells and not the cortical cells.
The cells will.
So you explained that the junction separates the cells for the cortex and then the cells for the medulla. Exactly. So I was asking, well, I want to understand if there is no differentiation, the cells surrounding the parts of the proximal, the medulla.
There's a noise. Just I don't know. There's a noise behind you.
Yeah, my place is a bit noisy.
Are you in the house?
Yes, please, I'm at home.
Or you are in your boyfriend's?
No, please.
I heard a male voice.
Hey.
I'm listening. So just when if you are telling me if this is not there, if the junction is not there, what happened? The cells at the cortex will be what?
I'm saying, will the cells still be the same at each point? So at the cortex and at the medulla.
Asking me a difficult question. Hey, if this is not there, so let me ask you a similar thing. I'm just acting like Jesus. When they asked Jesus question, then he turned and asked them, they say, let me ask you this. If your head is not part of your system, how would your system be? Your head on top of your body is not there. This is
The
what
body
you
will
are.
be floating without a head.
Will the body be will it be the body? It doesn't, this is separating this and it's making the kidney complete. So when you tell me we don't have this, you don't have the junction, then it means you cannot have this. Then it will be difficult for me to describe what will happen if you don't have the junction separating this. It will be difficult for me to say this will fuse with this. So in chronic kidney disease, what we say is that there's a poor cortical medullary junction. There's poor. There's no good. It means something has happened to this. So it's not making the boundary good. But we don't say the boundary is not there at all. Are you getting me?
Yes,
If the boundary is not there at all, then it will be difficult for me to say that if the boundary is not there at all, then these cells will move to this cells, will join to this. There won't be any differentiation. So let's think simple. This is PhD. If this is not there, what will happen? This is making the kidney complete, separating the cortex from the medulla.
Yes, Doc.
Yes, when you get me.
Yes, please.
If your hands are not there, what will happen? If your stomach is not there, what will happen? Just what will happen if your stomach is not there?
And then the body will be incomplete.
The body will be incomplete. So if it will be difficult for the body to be alive.
Yes, please.
So don't talk about assuming you tell me if the Bowman capsules is not there. Then it becomes a problem for me to say if the Bowman capsule is not there. The only thing I'll say, it will not make the kidney incomplete, and the kidney will be diseased or by default. Then it means you need a Bowman capsule. You need a Bowman capsule. So let's talk about something important. Very, very important. Let's talk about something important. This is the Bowman capsule. This is the Bowman capsules. Inside the Bowman capsules are capillaries. These network of vessels or capillaries, and we have this. We have the afferent arteries getting in, and these bringing blood into the Bowman capsules, and the efferent is taking blood out. Efferent is taking blood out. And blood coming here, and there will be filtration here. Be filtration via the podocytes. There will be filtration here, and this filtration will go through this, and this will be the proximal convoluted tubule. So I want us to talk about the pressures. This what happens. The varied pressures. The pressures that cause filtration here. What are some of the pressures that are involved to cause the hydrostatic pressure gradient? There should be a pressure gradient that should move filtrate into the tubules, such that there will be reabsorption here. Please, you get me?
Hold on.
You get what I'm saying?
Yes, please.
So let's talk about pressures that occur. Pressure, I'm talking about pressure. There should be pressure, and this pressure, there should be pressure here, pressure within this pressure. That resultant pressure should cause filtration here. So the resultant pressure that causes filtration here will be termed as hydrostatic pressure gradient. Pressure gradient. Hydrostatic pressure gradient. And this hydrostatic pressure gradient, that is the resultant pressure that is causing the filtration. So filtration will occur here, and before the filtration will occur here, there will be an opposing pressure. So when you have vessels like this, in the vessels, we have blood moving here. There will be an opposing pressure that will pose. If you are walking, mind you, you face opposition. Opposition will be air. At times, when the air blowing towards you is stronger, then it can cause you to fall. But because you are stronger than the opposing force, you can move easily. So when blood is moving here, blood will always faces an opposition. But because the pressure within this is stronger, then is able to overcome this. So the same thing. There's a pressure here. Blood coming here carries pressure. And this pressure, there will be an opposing pressure. And because if we are having filtration here, it means that the pressure here has been able to overcome the opposing pressure. And therefore we have what? We have the resultant pressure. And that resultant pressure causing the filtration is termed as hydrostatic pressure gradient or ultrafiltration. Ultrafiltration or GFR. What is GFR? So for you to get the GFR or ultrafiltration or hydrostatic pressure gradient going through this, it means that the pressure here has been able to overcome the opposing pressure. And now we are having a pressure gradient. And that pressure gradient is the same as GFR and also the same as hydrostatic pressure gradient. So ultrafiltration here, when we have blood coming from here, the blood will face pressure within the Bowman capsules. It will face pressure within the Bowman capsules. And that is one pressure, opposing pressure. So the one opposing pressure is Bowman space pressure. Blood from here will not go through those Bowman capsules without Bowman capsules resisting. So there's Bowman capsules or space pressure. Another opposing pressure will be we have within the blood, listen, we have albumin within the blood. Albumin within the blood. Mind you, albumin is negatively charged. Albumin is negatively charged. The endothelium, the vessels, the inner lining of the vessels here, the inner lining of the vessels here, the inner lining of the vessels here are also negatively charged, the inner lining. So if this inner lining are negatively charged within the capillaries and the albumin is negatively charged coming, what will happen? What will happen? Please, can you tell me what will happen? Please, do you understand what I'm saying?
Please, there will be repulsion.
Repulsion. So this will repair, will try to repair the albumin, and that will give the resistance to the flow. So this is coming, the inner lining is what? Negatively charged. The albumin within it is also negatively charged, so it will repair. So if the pressure within the blood is not higher than this, then it will slow down. So another opposing pressure is the oncotic pressure. So for ultrafiltration to occur, listen, for ultrafiltration to occur, now the blood coming from this, coming through this vessel, we term it as capillary pressure. So the capillary pressure, ultrafiltration is equal to capillary pressure, because the capillary pressure here should be greater than this opposing pressure. So capillary pressure minus into brackets Bowman capsules pressure, Bowman space pressure plus oncotic pressure. For ultrafiltration or glomerular filtration rate to occur, the capillary pressure, the pressure buildup within this capillary should be able to overcome the oncotic pressure in the Bowman capsules. Pressure buildup within this. Pressure buildup within, that is the capillary pressure, should be able to overcome the oncotic pressure and the Bowman capsules pressure. So this should be greater than the two, such that the resultant pressure will push this, will give us the ultrafiltration within the Bowman capsules. Please, is it clear?
Yes, please.
Yes, please.
Is it clear to everybody?
Hello. Please take it
Yes.
again.
Hello?
Hello.
Yes?
Take it again.
So this is what I'm saying. This is what I'm saying. There's a pressure at play within the Bowman capsules. We have capillaries here. We have capillaries here, and we have blood coming. I am saying for filtration to occur here, for filtration to occur, or for filtration to go through, for the filtrate to go through the Bowman capsules, the pressure buildup within the capillaries, within the Bowman capsules, which is glomerulus, the pressure buildup, the intravascular or the intraglomerulus pressure, the pressure buildup within, within this should be able to overcome any resistance, should be able to overcome any. What I am teaching you, please, very important. We are going to use it to answer a lot of questions. So take note and understand. I am saying the Bowman capsules here. This is the Bowman capsules. We have glomerulus, which is network of capillaries, and filtration occurs here. So I'm saying that bladder comes into the Bowman capsules, into the capillaries. When they get there, it's not like they get there and there's filtration easily. When they get there, they will face resistance. But because the capillary pressure is higher than the opposing pressure, there will be what? There will be filtration. So now we have blood coming into here. The pressure buildup within this should be higher. And the pressure buildup within the glomerulus is termed as the capillary what? Pressure. And this capillary pressure should be able to overcome the opposing what? Pressure. And what are the opposing pressures? So capillary, the CP, which is capillary pressure, is minus. Now we think about the opposing pressure. The opposing pressure is that the Bowman capsules will resist the filtration. And that is the Bowman space pressure. The Bowman space pressure. And it will be an opposing. Here you are pouring something into a funnel. Don't think that the funnel will resist the filtration. So that will be the space, Bowman space pressure plus there's an oncotic pressure. And that oncotic pressure is as a result of what? As a result of the albumin within the Bowman capsules. And I'm saying that we have capillaries. The inner lining is is negatively charged. And the albumin is also negatively charged. So it means that these negative charged albumin will try to, this inner lining will try to repair the albumin which is negatively charged. And this is also an opposing, would resist the capillary pressure. So this is plus oncotic pressure. Oncotic pressure, OP. And these oncotic pressure plus Bowman capsules pressure should always be less than what? The capillary pressure, such that we will get ultrafiltration. Ultrafiltration. And I'm saying that this ultrafiltration is the same as GFR. And it's also the same as hydrostatic pressure gradient. Hydrostatic pressure gradient. Please, is it clear?
Yes, please.
I'm asking the last time, is it clear? I should move on.
Please.
Yes, please.
Okay. I am saying this is very important because GFR is very important. Ultrafiltration, hydrostatic pressure gradient, these are all the same for filtration to occur within the Bowman capsules. Then your capillary pressure should be always be greater than the Bowman capsules pressure plus oncotic pressure. How do you increase the capillary pressure? Who can tell me? How do you increase the capillary pressure? Who can tell me? How do we increase the capillary pressure? The PC. If we have the Bowman capsules here, and we have afferent and we have efferent. Efferent. How do you increase the capillary pressure within the Bowman capsule? Within the glomerulus? How do you?
So, to increase capillary pressure within the glomerulus, I think we can increase blood flow, renal blood flow.
So we need to increase the renal blood flow. So how do you increase the renal blood flow? How do you increase the renal blood flow?
But by giving agents which will dilate the afferent artery.
So by giving what?
Agents which will dilate the afferent artery.
So which agent will dilate the afferent artery?
The angiotensin converting enzyme inhibitors or the ARBs.
Will dilate what?
The afferent artery.
So it will not dilate the efferent.
No, please.
So when you give a medication, when you give ACEIs, it will dilate here. It will dilate the A without affecting the E. Is that so?
Sir, please no.
Huh?
Sir, please no.
No.
So,
so tell me.
So they will dilate both the afferent and the efferent arteriole, but
so they will dilate this. They will dilate this. So let's learn something from here. For you to increase the intraglomerular pressure, which is the capillary pressure, intraglomerular pressure, which is the same as capillary pressure. For you to increase the pressure here, to cause ultrafiltration, to overcome the opposing pressure, the size of the lumen here should be small. So the size of the lumen of the efferent artery, efferent is taking blood away. This blood coming will go through the capillaries here and the filtration occur, and the rest will leave the Bowman capsules via the efferent arteries. It means that the lumen here should be smaller than the lumen here. Who can explain why it should be so? Who can explain why the lumen here at the efferent should be smaller than the afferent?
There were the efferent, as it's wider, you have more blood coming inside, and then you have less blood leaving. So there's going to be a pool of blood like inside the glomerulus, and that would create the pressure for filtration to occur.
So what of you are saying this is the A is bigger than the E, and because of that more blood will get here. That is the renal blood flow. More blood will get here. What of I am saying that the efferent to increase the capillary pressure or intraglomerular pressure within the Bowman capsules, the lumen of the efferent should always be bigger than the lumen of the afferent. And I need explanation.
Hello, Doc.
Yes.
So decreasing the lumen size of the afferent means it will lead to using more pressure to push blood through the afferent arteriole into the network of capillaries within the Bowman's capsule. So therefore, by decreasing it, we introduce more pressure into the capillary network. So therefore, we are able to overcome the pressure that comes from the capsule and then also from the uncurtailed pressure within the blood.
I didn't get your point. Can you speak louder a bit?
With regards to decreasing the afferent arteriole, it decreases the lumen size. So therefore, in order to get more blood into the capillary network, the body has to add a certain level of force to it. So it increases the pressure in order to push more blood into the capillary network.
Okay, let me ask you this. Now, this is your heart. This is your heart. This is the left ventricle, and it will pump blood via the aorta. Via this aorta. This aorta A, and we have another heart. We have left-sided pumping blood to the general circulation. This is aorta B. What is the difference between aorta B and A? In terms of the lumen, what is the difference?
So A has
The lumen in P is smaller, so the blood flow through that lumen will be via higher pressure. You increase peripheral resistance in that vessel, so the blood will flow with a higher pressure.
Higher pressure, good. So it means that for this heart, the left ventricle has to do more work to push blood through this. You get me? Is it clear?
Yes, please.
Because of the smaller lumen, the resistance that this side will face is greater than the resistance that this side will face because of the smaller lumen. Then it's telling me that from your physics, I don't know whether you recall your physics, pressure is equal to force over what? Area. So if the area is small, the pressure will be high. So if this area is small, pressure buildup within this will be high. And therefore you need stronger force to overcome the pressure building up within this. This is the same thing happening here. Now, when you dilate this, so we have bigger lumen, more blood will get into this. More blood will get, that is ensuring the renal blood flow. More blood will get into the Bowman capsules. For you to increase the capillary pressure here, then blood leaving this side, leaving the capillaries into the efferent arteries should face more resistance. And for this blood leaving to face more resistance, the lumen of the efferent should be smaller than the lumen here, such that the pressure build up here. Blood leaving the capillaries will face more resistance. And as it's facing more resistance, now pressure will be within. There will be more pressure build up within the capillaries to cause ultrafiltration. I don't know whether I'm making sense here.
Yes, please.
Is it clear?
Yes, please.
Is it clear to everybody, please? If you don't understand, let me know. So efferent arteries are always, the lumen of efferent arteries are always smaller than the lumen. So in order to ensure the increase in capillary pressure or the glomerulus pressure, the lumen of the efferent is always smaller than the lumen of the afferent, such that the blood leaving the capillaries or the glomerulus will face resistance. And that resistance would increase the capillary pressure such that it can overcome the Bowman and the oncotic pressure. Please, is it clear?
Yes, please.
Another thing, I am saying this is important. And I would, when I finish this, then you know the application. And the word, we talk about a lot of things, but you don't appreciate it because you don't understand this. Another thing that increases the capillary pressure is that within the lumen of efferent, we have AT2, a lot of AT2 receptors. What is AT2 receptors?
Angiotensin II.
So we have angiotensin 2 receptors. We have angiotensin 2 receptors. This is, we use the word ligated. So we use the word ligated. I'm using the mouse, so writing becomes difficult. So AT2 receptors are predominantly found within the efferent arteries. AT2 receptors are predominantly found within the efferent arteries. Therefore, the essence is that when we have AT2, this AT2 would also, in a way, also narrow the efferent artery. When you stimulate the AT2 receptors, it will also further narrow what? The AT2 with the efferent arteries to also increase the glomerular pressure or the capillary pressure. Please, do you get me? Take these 2 points. The lumen of efferent is smaller. The efferent arteries are having more of the AT2 receptors. Predominantly, AT2 receptors are found in efferent arteries. And these 2 parameters are helping to increase the glomerular pressure such that ultrafiltration will be increased. Do you have any question up to this point?
Doc, please can you take it for the balance?
I'm saying that we are talking about conditions or situations that will increase the capillary pressure. These are the Bowman capsules, and these are capillaries within. And there should be a pressure buildup within this to cause ultrafiltration. And I am talking about situations where these can cause increase in capillary pressure within the Bowman capsules. And I'm saying that the efferent arteries, the artery which is taking blood away from the Bowman capsules after the filtration, blood taking, vessel which is taking blood away is the efferent arteries. And I'm saying that efferent arteries are predominantly, they are having AT2 receptors. What is the function of angiotensin 2? What is the function of angiotensin 2?
To cause vasoconstriction.
To cause vasoconstriction. So if you are stimulating the receptors, angiotensin 2 receptors, it will cause vasoconstriction. So I'm saying that it will further narrow the lumen of the efferent. If it does that, what will be the effect?
There will be an increase in the capillary pressure.
It will be the increase in capillary pressure, and therefore there will be what? There will be what? More ultra
filtration.
So we increase the ultrafiltration. Please understand this. Understand this. So 2 things. You said that this is bigger. I'm going to now talk about the application. We are not learning this for learning's sake. I want you to get a basis such that you can apply. Now you talk about dilating this. Now, afferent arteries, the lumen is bigger. And the essence to ensure renal blood flow, to ensure that more blood is getting into here. Here is smaller. here is smaller. The efferent is smaller. To increase what? To increase the glomerular pressure or the capillary what? Pressure. So this should be bigger, this should be smaller. This will ensure the renal flow. This will increase the capillary pressure to ensure the filtration what? Rate or the GFR. Please, is it clear to everybody up to this point?
Yes, sir.
Yes.
Yes, please.
Now this is the application. Who can tell me, based upon this, who can tell me one or two medication that can cause renal impairment? And you tell me why. Based upon these explanations, bigger lumen to ensure renal flow, smaller lumen to ensure that there's filtration, there's increase in glomerular pressure to ensure ultrafiltration. Who can tell me? One or two medication that could cause renal impairment, and tell me why.
NSAIDs.
What?
NSAIDs.
So you tell me why NSAIDs?
So it's going to cause constriction of the afferent, which will decrease the capillary pressure, decreasing ultrafiltration.
NSAIDs is going to do what?
Cause vasoconstriction of the afferent arterioles.
So how will NSAIDs cause vasoconstriction? How will NSAIDs cause vasoconstriction?
Please, it's through the inhibition of prostaglandin synthesis. Prostaglandin E2 is known to cause vasodilation of the afferent artery. And since NSAIDs inhibits the production of these prostaglandins, there is going to be the inhibition of the vasodilatory effects of the prostaglandins.
Come again, please.
Okay, so NSAIDs are known to inhibit the synthesis of prostaglandins. And prostaglandin E2 is responsible for causing vasodilation of the afferent artery. And since NSAIDs inhibits its production, there is also going to be an inhibition of the prostaglandin-mediated vasodilation of the afferent artery, hence leading to its vasoconstriction or reduction in size.
Okay, so I want you to use technical terms when you are talking about prostaglandin. We have renal prostaglandin. And the technical term I want to use is that prostaglandins work locally. It's not systemic. You get me?
Yes, please.
So prostaglandins formation works locally. It's not what? Systemic. So what happens is that when you take NSAIDs, it will inhibit prostaglandins within the kidney. That is local effect. Autocrine effect. Autocrine effect. I will talk about it later. So now you are going to prostaglandins within the kidneys will try to dilate to ensure the renal flow. So when you inhibit the formation of prostaglandins, now to lead to what? Constriction. And that will reduce the renal flow. If you are reducing the renal flow here, it would affect the filtration because the amount of blood coming into the capillaries will be reduced, and that would reduce the filtration. So NSAIDs would inhibit the prostaglandins. That will affect the renal flow and would affect the ultrafiltration, which is the GFR. Another medication, which medication again? Somebody mentioned another medication. Another medication is ACEIs.
ARBs.
And ARBs. ACEIs and ARBs. When you take ACEIs, the reason why we say that ACEIs one can protect the kidney and can also cause renal impairment. ACEIs can protect the kidney and can also cause renal impairment. Let him talk about it. Because I'm doing this, let him talk about the renal impairment. ACEIs would inhibit AT2. AT2. It would inhibit AT2. So the AT2 effect will cause what? When you have angiotensin II stimulating the receptors, it will cause constriction. When you block it, then we are expecting a vasodilatation. So when you increase, will cause vasodilatation within the efferent arteries. What will happen is that now the pressure buildup within the efferent arteries will be reduced because you open up the lumen, the pressure buildup within this, and therefore blood flow through this will be easier. The blood coming from the capillaries will not face any resistance, and therefore it will reduce. When you reduce the pressure here, then the filtration here will also be reduced. So two medications that would affect or can cause renal impairment. It's NSAIDs. So when you take in more NSAIDs, be careful. Chronic use of NSAIDs can cause renal impairment. ACEIs can also cause renal impairment. Or ARBs can also cause renal impairment. Any question? Do you understand?
Yes, please.
You understand?
Yes.
Yes, please.
So let me ask you this, whether you can explain. We haven't gotten to that place, acute. ACEIs shouldn't be used. It's contraindicated in acute kidney injury. Why is it so? Why is ACEIs contraindicated in acute? So at the word, in acute situation, don't use what? Don't use ACEIs. Why? Can somebody help me?
Check please. In people with acute kidney injury, they normally tend to present with reduced glomerular filtration rates because of their impaired kidneys. So if you use ACAIs would cause vasodilatation of the efferent arteries. And once there's vasodilatation of the efferent arteries, it would further decrease the capillary pressure and further decrease the GFR of those patients. So it will end up worsening their case. So ACAIs are contraindicated in AKI patients.
So what is AKI? What is AKI? What is Sandra? I'm saying what is AKI? What is AKI? I'm not asking you to tell me the full meaning. What is AKI? What is AO? What is I'm not saying what is AKI? What is that? AKI?
Acute kidney injury.
What is listening to the question, what is I am not saying define this. I'm not saying tell me acute kidney disease injury. What is that? Do you get me?
Yes, please.
So what is that? What is
It is an abrupt kidney function, and it's usually characterized by accumulation of waste products.
So sudden reduction of what? Renal function.
Yes, please.
Are you done? So sudden reduction of renal function within 48 hours. Within 48 hours. So there's a sudden reduction of renal function. If there's sudden reduction, we don't know what is happening. And when you go and give your ACEI, which would also worsen it. So in acute AKI, please don't give ACEI. Contraindication of ARBs. Don't give it. Don't give this. Don't give it. Please, any question? Any question? So note this. Note this. If we talk about, who can tell me? We talk about cardiac output, the amount of heart and the amount of blood coming out from the heart. Who can tell me the percentage of cardiac output that will get into the kidneys?
It's
25%.
5%.
It's what?
25%.
85.
No, 25.
So 25% of cardiac output. 25 of the cardiac output will get into what? Will get into the kidneys. 25% of the cardiac output will get into the kidneys. And take note of these things. For an adult, the ultrafiltration and the GFR ultrafiltration or the GFR, the ultrafiltration or the GFR for normal individual should be what? 120 to 130 mils per minute per 1.37. That is the surface area. 1.373 meters squared. So for normal individual, the cardiac output, 25% of the cardiac output will get into the kidney. And that is supposed to cause GFR of between 120 to 130 mils per minute per 1.73 meters squared. That should be the ultrafiltration. The hydrostatic pressure gradient should be this. For normal individual, should be this. So this is telling you that for a normal individual, the ultrafiltration this is also important. For normal individual, the ultrafiltration in terms of amount of water coming out per day should be between 170 to 180 per day liters of water. So this is amount of water that should be filtered, 170 to 180 liters per day. And so because ultrafiltration is giving me this minus 1 this liter per day, this will not leave the system. This is ultrafiltration at the Bowman capsules. But because we have ADH acting at distal convoluted tube, some of these will be reabsorbed at the collecting duct. Some of these will be reabsorbed at the distal convoluted, the loop of Henle. Some of this will be reabsorbed. And therefore, for a day, urine that should come out should be 1 to 2 liters. 1